Thank you, Dr. Campbell. Dr. Rosemary Lesser will be our next speaker, and she's speaking on contraceptive use and safety. Dr. Lesser recently retired from the Ogden Women's Clinic after practicing there for 20 years. Prior to that time, she was an obstetrician gynecologist in the Air Force. She is a graduate from the University of Notre Dame and will gladly welcome BYU fans to the Notre Dame campus this October, including personal tours. Her future plans include third world medicine projects for cervical cancer reduction using HPV markers, also selling with her husband Dave, and working as a laborist. Why don't we welcome Dr. Lesser.
Thank you. Can everyone hear me? Yes? Good. My talk today is on contraception. But first of all, I wanted to recognize all the fellow retired physicians in the room. I have to tell you that I truly understand why you are here, that being a physician is part of lifelong learning, and the need for intellectual stimulation is intense. Similarly, I'd like to recognize all of the junior physicians who are here and applaud you in your beginning of your journey in medicine, which has been truly rewarding for me, and I encourage you in your continued learning. I also did not pick a really snazzy topic like Tim Howden did yesterday. Unfortunately, as you know, contraception is one of those topics that can gender some heated responses and so forth. So we're just going to stick with contraceptive update. I decided that things like contraceptive misconceptions might be poorly received. So let's go on with the show. As all of you know, we are required to have a disclosure. I have no personal or financial connection to any pharmaceutical companies. This doesn't say pharmaceutical companies, but that's okay. This is a picture of my husband and I, and the very first thing that we did after we left Ogden Women's Clinic is we went to Australia. You probably recognize the Sydney Opera House there. Some people think that we were posing for the cover of AARP magazine, but this was taken on a bicycle tour. And the reason I bring this up is that if any of you have traveled to Australia, you realize that even though they speak English, they have some variations on English which I think are quite endearing. And one of them, of course, is if you've been there, they would say that you have just finished brekkie, which I thought was a pretty good way to talk about breakfast. But my favorite really was about talking about your relatives. And they called them rellies. And the reason I bring that up is that in a talk about contraception, let's pretend that this is actually Thanksgiving dinner, and you've invited your, let's say, rellies from the Bay Area, and we've decided in this conversation and in this meal to not discuss politics and not discuss religion. I realize that this can be really a pretty emotional topic for some people, and today I'm going to just discuss some salient features about the issues of contraception, and we won't delve into who should use it, how much it should cost, and things like that. So the goals, and as all of you who've been at these type of lectures before know, that we'd like to outline what we're going to tell you about. So I'm going to talk about the mechanism of action and relative efficacy of selective contraceptive methods. Well, when I say selective, in 30 minutes, there's no way we're going to discuss every particular contraception that's available. I'll add right off the bat that male contraception is still in the testing phase and probably has a long way to go. So we're going to just discuss selected contraceptive methods. If I didn't discuss your favorite contraceptive controversy, you can ask me questions at the end or tackle me in the, during the break. We'll also talk about where to find a simple resource for absolute and relative contraindications to different contraceptive methods. And this is really, really easy in the computer and smartphone era. I also want you to be aware, and we'll discuss some of the emergency contraception methods, commonly called the morning after or a few days after. And then, most importantly, we're going to refute some of the commonly held contraceptive myths. How many of you have ever been involved in CME programs or conferences where you get to click in your answer? Have any of you done that? Good. The thing that I like about it is I think it's sort of a follow-on to the world of American Idol and The Voice and things like that, that everybody gets to express their opinion. Well, we don't have clickers for everyone today, so this way you're going to sort of have to mentally do your little clicker, and I'll be asking you some questions. This way, in your postprandial mood, you can be engaged with this conversation. So, let's start off with a question. Which of the reversible, that's one of the key questions, contraceptive methods has the lowest failure rate? Okay, so think about this. Is it Implanon or Nexplanon, which will be replacing Implanon? Is it the Mirena IUD, or intrauterine system? Now, by the way, I realize if this was an academic presentation, I would say things like the levonorgestrel releasing system, and I would call the copper IUD by its number name and so forth. But for since we're all friends here, I'm going to just use brand names, and don't be offended. Or is it combined oral contraceptives? So the answer, I didn't give you much chance to think about this, was Implanon and Nexplanon. The thing about this is that the Implanon is in one of those categories as what we call long-acting reversible contraception. And the reason it's so effective is that once the device is in, it's in. And so a woman doesn't have to think about taking a pill every day, making sure that the barrier devices are in the drawer and things like that. They just have the device inserted. So for those of you who may not be familiar with Nexplanon, basically this is a device that is inserted into the arm. A person has to be trained to insert this device. It's effective for 3 years. It prevents ovulation by a slow release of a synthetic progestin. It works by not only inhibiting ovulation, but also by thickening cervical mucus, and it's very, very, very effective. The initial studies, the Pearl Index, there were very, very few pregnancies in this category. And there are very few contraindications as a progestin-only, not estrogen-containing device. The big problem with this particular contraceptive is that the bleeding pattern is unpredictable for women. Only about a quarter of women actually have amenorrhea. So you can't say to a woman that you're counseling for this device, you won't have a period again. In fact, the majority of the time, women will have some erratic bleeding. For those who really have troublesome bleeding, you could use supplemental estrogen, you can use a few cycles of oral contraceptives, provided that they don't have any contraindications for that, and actually even an anti-inflammatory like ibuprofen may be helpful in that situation. Now, as I mentioned earlier, Implanon will be replaced by Nexplanon. And the main difference for Nexplanon is that there will be a little bit of barium inserted so that you can find the device. So it will be radio opaque. If you've had to search for Nexplanon, you actually had to do an ultrasound of the arm to find the Implanon. The insertion device was also improved, so it could be done with one hand. The other problem with Implanon, and this was what was responsible for 3 of the 6 reported pregnancies, is that the device actually was not in the patient's arm. It had actually fallen on the floor. And that does not prevent pregnancy with a device which is now attached to your shoe. So they invented a new inserter that keeps the device in until you actually put it into the arm. And it actually, you have to go through training through the company. If you're an Implanon trained inserter, you could do the Nexplanon training online. And the way the device was modified is that it was less likely to really go deep into the arm with the new insertion device. So just something to keep in mind, and it's very, very effective. Now, for those of you who did not answer Nexplanon or Implanon as your answer, there is a consolation prize, because close to the implant is the intrauterine device as the next in the long-acting reversible contraceptives that are available, which also have a less than 1% failure rate in women. And these are the 2 devices that are on the U.S. market. The Paragard IUD, which is the copper device to your left, and the Mirena IUD, which is on the right. So the Paragard is approved for 10 years, so this is very, very effective for women who are at any stage of the reproductive life, but certainly for a person who really wants prolonged contraception. Even though these devices cost around $500 when you amortize it over 10 years, that's not incredibly outrageous price for 10 years of very effective family planning. The device slowly releases copper, which is toxic to sperm flying past it. And so in studies looking at the viability of sperm, in which they did tubal ligations and they did tubal washings to look for viable sperm, there was not motile sperm after that had swum past or tried to swim past the copper IUD. So this was actually pretty encouraging in terms of people who were worried about this particular device as an abortifacient, which actually it likely is as a as a morning after event, but that's a different story. I'm talking about the Paragard as a birth control method. The new packaging on this drug approves the use in nulliparous women, and it can be inserted in a woman who has not had a child. And the other thing to keep in mind about the IUD is that for many of the senior physicians in the room, they think about some of the older IUDs, like the infamous Dalkin Shield, which was particularly poorly designed with its multi-filament string, which allowed all sorts of bacteria to swim up those strings. For both IUDs, the Paragard and the Mirena, after the first 21 days of insertion, when you've entered that sterile cavity of the uterus, well, not you personally, but the IUD, the rate of pelvic inflammatory disease with an IUD is no greater in IUD users than similarly matched controls. Now, similarly matched controls is the key word. It's other people who don't use contraception. So, but in studies on this, the PID rate that was often feared by people is not as high. The main side effect with the Paragard is heavier bleeding. And for many women, this improves over time, but a very cheap thing to do is encourage them just as soon as their period starts to use Anaprox or ibuprofen. That actually, there have been very good studies showing that this truly does decrease the rate of menstrual flow. The medication Lystedra that was discussed yesterday in our trauma lecture has also been approved for treatment of heavy periods, but that's a far more expensive drug and would probably be reserved for the person who had bleeding not controlled by nonsteroidals. And as I mentioned earlier, this is one of the very, very, very effective forms of emergency contraception and can be used up to 5 days after the event. Next, I'll talk about the Mirena IUD, which is really gaining in popularity. And one of the reasons that it has become very popular for women to use this, once again, is that it's not something that they have to think about every day. And the other benefit of this, and certainly one of the non-contraceptive benefits of this particular device, is that there's markedly less bleeding in most women because of the way that this particular device works. The endometrium is much thinner, and in fact, in Europe, not only is this drug very popular, drug-releasing device, as a contraceptive, but it's the most commonly used treatment for heavy uterine bleeding. They don't go with ablations as much as using the Mirena. So this endometrial atrophy promotes a endometrium which is appealing to women in that most women have much, much, much lighter bleeding with this particular device. It's approved for contraceptive for 5 years in the United States. The device is actually made in Finland, and in the European Union, this device is approved for 7 years. The reason I mention the 5 versus 7 years is if you're using this device to treat heavy bleeding in a woman who has another contraceptive method like spouse with vasectomy or tubal ligation, there's no reason that you need to pull it at the 5-year mark because it's still likely going to be hormonally active for at least 2 years after that point. So for women who are not using the Mirena for contraception, I say leave it in as long as it's doing what it's supposed to as far as lightning periods. So, ready for your next question. Which group of women should not take combined oral contraceptives? Okay, got your brains engaged? Okay, women who have migraine with aura, women who have had a baby less than 21 days ago, smokers over 35, or D, A, B, and C. Now, for all of you who've taken standardized tests, I know that you're pretty crafty on this, so that if you know one answer or maybe two, then you know the next. All of the above. So I'm not going to go over every single contraindication to oral contraceptives. I would clearly be having amazing nodding out if that was the case. But I did want to bring up a few points that are relatively new. One of them has to do with the not taking oral contraceptives postpartum. So that, as all of you remember from your early days in medical school, and for those obstetricians in the crowd, you also know that up until the 20th century, and unfortunately into the 21st century, postpartum hemorrhage was the leading cause of death. Well, unfortunately, in the United States, fortunately, we've gotten a really good handle on controlling hemorrhage in most of the cases. However, now the leading cause of death in developed countries is thrombosis. And Dr. Campbell knows that thrombosis prevention is really one of IHC's big focuses this year. So, oral contraceptives should not be used in women, especially in the first 3 weeks after delivery. And even as you look at the CDC guidelines, it should not be used for most women. They have a whole big list, like if you've had a C-section, if your BMI is over 30. Now let's face it, which postpartum woman doesn't have a BMI over 30? Oral contraceptives should not be especially oral contraception should not be used in the first 6 weeks after delivery. The thing that I wanted to bring up to you, and this is an easy resource, and it was endorsed by ACOG, the American College of Obstetricians, is the CDC has put together a fabulous resource for you in which they adapted from the World Health Organization medical eligibility criteria for contraception. So I'm not going to give you a URL on this screen. I've been to so many lectures where they give this complicated URL, and if any of you have ever tried to go to a government website, you know that the URL is twice as long as anybody else's. But if you just Google USMEC, you'll get to the page that tells you what should you do with your patient with cirrhosis, or what should you do with your patient who's had a thrombosis, or what should you do with your patient who is undergoing breast cancer treatment, or things like that. So it's an exhaustive list, and the categories are very straightforward, 1 through 4. 1, great to use, no problems. 4, don't use it. So very straightforward. Now, the thing to remember is that even though we're talking about contraceptive safety, we have to remember that the alternative pregnancy is statistically riskier than any hormonal contraceptive. Well, just following on the recent Mother's Day celebration, I have to thank all the mothers in the room who decided to take that chance. But remember that the thromboembolic risk for just being pregnant is 10 per 10,000 women, so all of us are going to see that. And the postpartum period, it's 50 per 10,000 women. Hormonal contraception, even the, quote, riskiest hormonal contraception, is around a risk of deep venous thrombosis of about 5 per 10,000 women. So no talk on contraception would be complete without talking about combination oral contraceptives. When people think about birth control, thinking about the pill is what usually comes to mind first. The failure rate of oral contraceptives when taken perfectly is really pretty good, about 1 to 2% per year. Although, if you're in the 1 to 2%, may or may not be such a great thing for you. But remember that these pills contain both estrogen and progestin. And until pretty recently, it was easy to figure out about what were risky, is that estrogen seemed to be the bad actor when it came to thrombosis. However, there have been some recent reports on some of the newer progestins that have discussed the thrombosis risk associated with them. So in our efforts through the years, the dose of estrogen has gone down, down, down. The first oral contraceptives had 100 micrograms of ethinyl estradiol. There are currently products on the market which only have 10 micrograms of ethinyl estradiol, all in an effort to try to reduce that thrombosis risk. So I'll talk about the latest trend in contraception, at least as far as combined oral contraceptives, is decreasing the hormone-free interval. So originally when the pill was developed, they kind of just picked 3 weeks on and 1 week off, kind of randomly, to try to duplicate the menstrual cycle. Well, let's face it, the birth control pill is not designed to try to duplicate nature. Nature is designed to reproduce, so we're actually trying to thwart Mother Nature, not duplicate her. So in these, when I say decreasing hormone-free interval, we're talking about extended cycle pills. Pills in which women take active pills for 90 days and then have a break. Okay, time for the next question. Oh, I wanted to just back up for just a quick second about yesterday some of you heard that triphasic oral contraceptives were risky and all of that, or change libido and so forth. Subsequent studies, not true. Okay, another myth. So here's my next question. Oral contraceptives containing which progestin received a black box warning last month stating that patients should be counseled about increased risk of venous thromboembolism? Levonorgestrel, norethindrone, drospirenone, and norgestimate. Okay, drospirenone. This is part of the dermatology part. Because this is a progestin with a unique mineralocorticoid activity, which was really promoted to the dermatologists saying that this was going to be better for acne and so forth. Unfortunately, this drug also carries with it the risk of increased potassium, increased risk of thrombosis. And these drugs that contain drospirenone are Yasmin, very popularly marketed drug, Yaz, Byaz, and many generics. Quick parenthetically, with so many generic drugs on the market, many times you don't know what in the world is your patient truly taking. So once again, Google what drug she is on. The group that voted on this, the vote was 15 to 11. 11 people were in favor of actually taking this drug off the market very recently. So beware of drospirenone. Ortho-Evra also got a black box warning because of increased risk of thrombosis. Still not as high as pregnancy, but higher risk. Ready for next question as we wind up? Which antibiotic is associated with increased risk of oral contraceptive failure? This is one of those big, frequently comes up questions. Ampicillin, tetracycline, rifampin, all of the above. Right, rifampin. This is another myth, get rid of it. Antibiotics do not make oral contraceptives fail. I'm bringing up natural family planning only to address the fact that there are classes offered at McKay. The pregnancy rates are very, very much user dependent, and this can actually also be used for people who are trying to become pregnant. It can be used in both directions. Emergency contraception, I talked about Paragard. Plan B and Ella are two new oral. Plan B is relatively, has been around a while, and that is available for women 17 or older behind the counter. It can be given by a pharmacist without a prescription. So in conclusion, we've discussed some of the commonly held myths. We've talked about some of the risks of oral contraceptives. And if anyone has any questions for me, I'd be happy to discuss them with you at the break. If you have anything burning right now, feel free to bring it on. And last, I'd like to introduce my daughter. This is my daughter, Erin, and she will be starting her obstetrics and gynecology residency in July, so the circle goes on. Questions? Yes.
So, in someone who's had venous thromboembolism, is there contraindication to using progesterone-only products like
Right.
IUD and the
Yes.
pill and
Yes.
Equinox?
Yes. So the question was, can a woman who's had a previous thromboembolism use a progestin-only contraceptive? The answer is yes. That's an ideal choice for that particular patient, including the Mirena IUD, although the package insert does not reflect that. In that US MEC document from the CDC that I mentioned to you, it is considered an approved device. Package inserts often don't catch up quite as fast. Black box warning catches fast. By the way, if you're interested in how quickly you can follow the FDA, I thought it was interesting that you can now follow the FDA on Twitter, that they will tell you when there is a new black box warning. Unfortunately, I usually hear about the black box warnings from various things like the New York Times. Any other questions? Well, I can catch you at the break if you have anything personal.